So we now have Murali Ariga, who's practicing in Chennai, and he's the right man because anytime we have a new device or a procedure, he's already done it. So we are really impressed, and I think he's the right man to tell us how he escapes from litigation and how does he avoid it.
Thank you, Dr. Harsh, and I think I must particularly thank AOS and Professor Tanuj Dada for inviting me here to speak on a non-glaucoma topic in a glaucoma subspecialty day. Anyway, without much ado, I think this is more like a break from your listening to glaucoma. So you do know, I guess, that you can choose your patient for treatment, but only when a non-emergency. When a patient comes in with a situation which is not an emergency, you have to accept the patient for treatment regarding on the clinical situation where you work in which hospital. It is a contract. Once you accept a patient for treatment, once you start and accept a patient for treatment, you have to provide the treatment, complete the treatment, and once you decide to take on a patient for treatment, the patient is yours till you complete the treatment. You must understand that. In an emergency situation, the law is very clear. You don't have a choice as a medical professional. You have to treat every patient who walks into your clinic for any emergency, be it a cardiac emergency or a neurological emergency or an ophthalmic emergency. So as a doctor, you don't have a choice in emergency, whereas in a non-emergency, you have a choice of taking up a patient for treatment. You can refuse to take a patient for non-emergency. Once you accept a patient for treatment, go on to complete it because you break the contract otherwise. Consent is the most important aspect of treatment. Many of us don't understand the various aspects of it. Has to be prior, it has to be voluntary, it has to be informed. It's not just consent, it's prior, voluntary, and informed. Some of it is implied, some of it is expressed and written down. But if you do something on a patient without a proper consent, it is assault and battery. A person's autonomy has to be respected. You have to take consent before any procedure, prior informed consent. Under civil law, you are liable for battery. Under tort laws, under criminal sections, now the IPC has changed to some other code now. The numbers have changed. But you are liable for criminal action as well if you do things without consent. So as I already mentioned, patients should understand the risk, benefit, and the alternatives. Is there a choice of not doing or doing something else? Use non-medical jargon. Don't hide behind literature. Don't hide behind technology and so on. Any medical term should be defined. Take time to address questions and concerns and document everything. If you have documented the consent process, it is very important. Make sure signatures are taken. A consent is a legal document, can be produced in court. There is no need to take video consent. The law does not demand a legal consent. You don't have to video record. It may add and corroborate things, but a video recording is not necessary. An audio recording is not necessary by the current law. And how much information do you want to provide to the patient? Is it all available information or relevant information? I think you need to balance as a clinician as to how much information do you need to provide. In the US, it is all available information. In the UK, it is all relevant information. In India, it's a balance of both. This particular case I would like to highlight among...
But Murali, if the patient says that he just got it signed from me,
it is illegal. He can always turn around and say that I've just signed it, I've asked to put my thumb in.
So that time, don't you think a video...
It is not a valid consent.
No, then if that time you have an audio...
Does the video show the paper being signed? Does it
yes.
show the document, all the details
and
of the document?
You are asking that, have you understood every point? And he says yes. Will that be valid? Will it corroborate?
No, it's still not valid. The advocate is smart enough. He will say, they gave me a paper. I did not understand the language. It was shown to me. I was asked to sign here. Under duress, I signed.
But for clinical trials nowadays, they want video consenting.
Yes, that is additional only in certain clinical research trials you can do that. But for a regular consent, it is not necessary. So that is a background in which we all work today. It is a problem. So you need to do things properly. Take patients into confidence. The people simply turn around and say, I did not sign it. I signed under duress. If you signed under duress, it is not valid. It's not prior. It's not voluntary. So make sure you understand that. This is a classic case of somebody who was posted for a procedure, and during the surgery under GA, something else was done, asking the mother of the patient. The patient after the surgery, it's a young woman, and it's a very famous case, so the Supreme Court case, so everybody quotes this case as a precedent, we call it. A consent given for one particular treatment procedure is not valid for any other procedure. You can only take one procedure. Suppose you did not do it during the surgery, don't do it, just stop it, unless it's an emergency or a life-saving procedure, don't do it. Stop it, go back another day and do it. Legally, it is not valid to do good for the patient in that sense. You are actually assaulting the patient by doing extra procedures without proper consent. For a phaco trap, for example, you need an anesthesia consent, you need a phaco cataract surgery consent, IOL implantation consent, you need a trabeculectomy consent separately. How many of us take separate consents for combined procedures? We need to take separate consents, and it's mandatory by law. You cannot take a blanket consent saying surgery and proceed, exam and proceed. All this is not allowed in the law. How about YAG iridotomy? How many of you take consent for YAG procedures? About 50% of you. An YAG iridotomy is a surgical procedure. You do need to take consent, and you can end up with situations like this and litigation when patient does not see. The ethical regulations of 2002 are going to be modified, and need to have a duty to your patient, to your physicians, to your colleagues, to your staff, how you deal with misconduct and various aspects. The ethical regulations have been published in 2002. They're going to undergo modification. You will hear about this shortly. I think the generics part of what came from the NMC was just a short kind of a trailer of what's going to come in the future. Unethical advertising, soliciting, practice within your specialty, and refer out what you don't handle. Do not hesitate to refer out what you do not handle. Remain within your specialty. Don't do something which is not your expertise. Don't fiddle around with that. Simply refer out. Unethical advertising like this clearly is wrong. And you have another situation where you make a sarcastic or a casual comment during a local anesthesia procedure. A surgeon in Ahmedabad was hauled up and asked to pay 1 lakh because during an intravitreal injection, there was a vitreous hemorrhage, and the patient filed a suit asking for compensation because he felt that the doctor was casual, was talking to somebody and did not pay attention. So the vitreous hemorrhage could have been anything else, but the court held that he was talking and casually talking to his anesthetist, and that is why the bleeding occurred. So do not make casual conversation, do not pass sarcastic comments, do not pass comments on some other professional's treatment. Don't, oh, this is the way it was done. Oh, this is not ocular hypertension, this is not glaucoma at all. So never do that. Be diplomatic, be kind to your colleagues. Reserve your comments to yourself. What is in front of you, that is the only evidence available. Communicate well. Effective communication definitely reduces litigation risk. Communicate clearly, and lack of communication is one of the biggest problems we face in litigation. Listen to the patient proactively, listen to their concerns, do not brush them aside, investigate any problems, anything the patient or relative has a concern, alleviate the patient anxiety. This will go a very long way in going ahead to what the patient might suddenly turn up a year later and file a suit against you. Under the current laws, up to 3 years, the patient can come back and file a suit against you. And sometimes the courts condone that even longer time may be taken for them to file a suit. Risk management, alleviate risks, look at protocols, make sure you don't make mistakes where the errors are going to happen and so on. Prioritize patient safety in your practice and regularly assess your systems. Involve your staff. Your staff is the one, we are all highly skilled maybe, but you don't involve your staff and you don't train them to handle the procedures, the consent forms and so on. Employee training, confidentiality, to make sure they understand what is confidentiality, not to share data with others. It's a very important aspect of the legal aspect. Maintaining medical records is extremely important. IP records for 3 years, OP records depending on your hospital protocol. We need to move on to digital recording and make sure there's a good backup of all the digital records. Anybody asks you for a medical record, you must provide it within 72 hours. That's a current law. You are mandated by law to provide a report within 72 hours. If you do not do it, you are liable for a lawsuit. Medical records are also now governed by the Right to Information Act. Under the RTI, a patient or a person can file against your hospital asking for information, asking for records from your hospital. The RTA is applicable to hospitals as well, and to us as private practitioners. Illegible handwriting prescriptions like this. Make sure you get enough indemnity cover depending on your practice level and what kind of surgeon you are. Make sure you review this policy periodically. Without indemnity, do not practice. And know the law and the legal system. This particular statement means that if you do not understand the law, it is no excuse. You have to understand certain aspects. This is one of our review articles published recently on medical legal aspects of ophthalmology in India. It's a 2-part article. The second part is yet to be published. You know that all clinical establishments have to be registered under CEA. There are guidelines under CEA. We all know that we follow under the CPA. And some people mentioned recently that the new amendment of the CPA in 2019 that medical services don't come under the CPA, Consumer Protection Act. We do remain Consumer Protection Act. We are liable under CPA. Patients are consumers. We are providers. We are not any noble profession and so on. So medical negligence, one last word before I close. What is medical negligence? As a doctor, a practitioner must bring to this, very important to understand as a doctor, that bring to your task a reasonable degree of skill and knowledge, a reasonable degree of care. You don't have to provide the best available treatment, the best available technology. That's how all courts look at it. Are you providing reasonable care, standard of care? Do not provide anything extraordinary, but do not provide something very low level of care. So that's all is expected from a practice. Do not panic when you have litigation. You do have legal cells, like in our own state. I head the Tamil Nadu legal cell, and so on. So take home message, litigation is an ever-present concern for practitioners. Even though we consider ourselves a noble professional, do not trust anyone blindly. If you have a doctor among patient relatives, you are sure that there are going to be more queries than usual. It is usually the doctor relatives or patients who start the litigation. Always be wary of doctor patients and their relatives. Don't be too nice to them. Be professional. And lastly, safeguard your practice. Where years and decades of practice may crash with just one single episode or incident. Be proactive, mitigate risk, promote patient safety, and ensure compliance with the law. Thank you.
Thank you very much, Dr. Murali. That was, in fact, a very, very informative talk. I'd just like to ask you one question, Dr. Murali. Do we need to retain our records for 3 years only?
The inpatient records, according to the current law, is 3 years. You can retain for longer than that.
Yeah.
Again, depends on the situation. If the patient is a child, you must retain it at least till 18 years of age. If it's a medical legal case, till the case is resolved, conflict is resolved, you must keep the record. So on, as far as possible, keep it to the extent possible, but 3 years is mandated by law for inpatient records. Outpatient, it's your hospital policy, you can keep it for as long as you like. Digital, you can keep it much longer, but 3 years is the mandated period.
Okay, just one more question is that many insurance companies nowadays ask for the original documents, indoor documents. Do we have to give them? Is that a valid thing?
Yes, if you have signed an MOU with the insurance company in the beginning, saying that you have accepted to provide records, you can give a certified record, you can give a good photocopy, and you can also provide the original, but you can make sure that you have received a document from them saying that they have received the original. You keep a copy, certified copy, and say so-and-so from this insurance company has taken the original. Make sure they sign it and give it back to you. And you can even video document, that's more important to video document. Right. So they take it away and they lose it, you are in soup.
Absolutely.
So the courts will always ask for the original. And recently we had a patient in an emergency department in whom the court could make out that the handwriting was not legible. They made the doctor stand on the dock and literally asked him to read out the case history. He just could not read his own handwriting. They knew he could not read, but nobody could read. So much of sarcasm said, doctor, you're not able to read your own handwriting. Are you sure you did the correct treatment? Do you know what have you written? So that sarcasm, make sure your records are clean, and whatever you have, don't tamper with them. Go with original records and revise them, and don't say anything what is not in the record. Always state only what is in the record. Don't give your own conclusions. Don't give your own advices and evidences. What is there in the record is what the court will take.
Murali, tell me one thing, if you have taken a good consent, will judge pardon you if the patient suits you?
No, a consent is a legal requirement. Whereas the patient, no, it is because it's what we call it, we are human beings. We have an autonomy and a right over ourselves. So suppose I don't like the way somebody is treating me or talking to me, I have the autonomy of doing something for myself. That is the law. Under the Constitution, it's a basic human right that you have autonomy. So anybody cannot, do something against the autonomy of a human body until he or she directly authorizes that. So any intervention on a body has to be authorized by that particular person. So consent is only a beginning of a legal process. Suppose how the patients come in to sue you is because of negligence. So to proving negligence is a different issue altogether. People don't sue you for consent. A consent, if you do not have a consent, you will be taken up over and above negligence. You will be taken up for assault, battery, and criminal negligence as well. So it's not only the consent, it's not only the negligence. The negligence is a totally different issue. Under negligence, you have civil and criminal. So the criminal part is the gross negligence. So there's a huge amount of data which we need to understand as far as the law is concerned.
We have to have more discussions.
I know 7 minutes is too short to even introduce the subject to you.